just for clarification, are we going to do this as a conversation? In other words, will the podcast be just kind of a back and forth, just so I can get the rhythm of it?
Yep.
Good. Okay.
No, I'm going to say something, and then you agree with me, Mark, okay?
You sound like my wife.
Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today we have two guests. We have Paul and we have a Dr. Mark Shapiro. Everybody knows Paul, so Mark, if you could, please introduce yourself.
Yeah, I'm a trauma surgeon. I trained in Cincinnati and worked at a few places, including UMass, Duke, where I was the chief of acute care surgery, and then the medical director at Grady for trauma.
Well, outstanding. Obviously, you know exactly what you're doing, and that's why we got you on the podcast. The reason why I asked you to come on is I see a lot lately more advanced procedures wanting to be pushed out to the pre-hospital environment, namely like REBOA, but other procedures that people bring up are like abdominal type surgery as far as hemorrhage control goes for blunt trauma. And they come to me asking, well, you know, if it's an open abdomen, I can just go in there and clamp with no problems. You know, why can't I do the same thing for blunt trauma, say with like a liver laceration or, you know, some type of splenic injury? And so I asked you to come on just because of your experience doing surgeries like that. You know, what kind of risks go into making the decision to go into the abdomen?
You know, Dennis, that's a great question. And I have, you know, a fair amount of training, actually a lot of training in the civilian world. And thanks to good folks like you and Paul and third group, I've had a lot of exposure to the 18 deltas. And that doesn't mean that I have true experience downrange, but I have a greater understanding of the environment in which you work. And I think it's different between the civilian theater and true, you know, medicine, austere medicine, such as you encounter on a daily basis. So in the civilian theater, it's very easy because we have most, if not every, of the resources we would need at hand, whether it's in the trauma bay or, you know, just a few feet away in the operating room. So when we do exercises, prolonged field care exercises with the 18 deltas, I think you have to think more like an 18 delta than you do a trauma surgeon. And yet the consequences of making those decisions are immediate life and death, or sometimes at worst, prolonged life and death. So I think the quick question that one needs to ask themselves downrange is, not only can I do it and do I have the competencies to do it well, but what are the consequences once I execute that maneuver? So REBOA has been a hot topic, especially with us in the civilian theater, and can it be pushed out to pre-hospital with EMS and so forth? And it's one thing to stop the blood supply from the aorta, and it's another one to bring that patient to the hospital and then to unclamp or let the balloon down, if you will, and how to deal with that patient minutes to even hours later. And it's very likely that the consequences are much higher than many of us expect. So the reviews right now about the REBOA are quite mixed, and clamping off the aorta to save somebody from a pelvic fracture versus somebody from a large thoracic injury continue to have mixed consequences. And the ones that we always talk about are the few lives that have been saved by that maneuver. And how do you pick your patient so that they're the one saved and not the one that suffers the consequences of cold legs or emboli or things like that? I think we need more research to figure that out.
So take an example from one of the many cases I'm sure you've had. What are your decision points to say, okay, this is a surgical abdomen versus this is something that we should try and tackle, I guess non-surgically?
So at home, where I'm at home most comfortably is the operating room. And so if I can't get to the place that I'm most comfortable with, the question in my mind is, do I have enough time to place the REBOA, which is not something that takes just a couple seconds. It actually takes several minutes. And the more we place, the more comfortable we become placing it. And arguably more importantly, the nurses and the techs who bring the supplies to the patient to begin to insert and then deploy the REBOA is that time less than it takes to run up to the operating room. And doing that in a patient with a thready, if almost non-existent pulse is exceedingly difficult because the key is to find that artery. And so many people will place an arterial line immediately in a hemodynamically unstable and hypotensive patient in an effort to quantify what their blood pressure is. And again, if there's an OR that's available or not available, they have to make that decision where they're going to deploy the REBOA. What would that look like in an austere environment? I think would be actually quite simple. But again, we would probably not look for the most sterile environment, but at least a clean environment. And with the aid of the ultrasound, which many of you are now being trained to use, and some of you actually are quite facile with the ultrasound, you would use that to identify the artery and get access right away. And I think your training is most excellent, and I think you are much better at decision making and going down that route and committing very, very early. And so there may be an opportunity if we find that you have access to a more advanced area to treat these patients. But right now, I'm very concerned that some of the 18 deltas who have gone through some of the REBOA courses, which are very fine courses, will use the REBOA instead of transporting that patient earlier, or recognizing that unfortunately this is there's a fatal injury and they may not be able to do much. Like most research, however, you got to ask the question.
Right.
So, Mark, where do you see it being most helpful for us, as pre-hospital providers?
Right. Well, I see the bad pelvic fracture, and I don't know that that's dissimilar to ourselves, but those zone 3 injuries where you're not compromising flow to the bowel, you're not compromising flow to the viscera itself, and certainly not the upper extremities, but perhaps sacrificing everything below the umbilicus in an effort to save that patient's life.
One thing you talked about is making the proper decisions. Now, when something like this severe pelvic fracture happens, if you have a transient responder who is responding to blood, but they continue to bleed, and blood is a finite resource in most of these environments, are there other options besides REBOA, or better options, or how do these other options compare?
I think that is the question. And unfortunately, other than direct pressure, which can be difficult in many instances, especially in the area of the iliacs, there aren't very many options. There are the topical hemostatic agents, which you might be able to flood the abdomen with. A colleague of mine at MGH is working on a very interesting device that I do not believe has been approved yet to insufflate the peritoneal cavity with a Play-Doh-like or putty-like substance, which appears promising in experimental animals, if you will, and potentially could be helpful for the intra-abdominal hemorrhage. But other than that, and some of the topical hemostatics, which really, from my understanding, have kind of failed in the field, there aren't very many options.
Now, the one that I really did want to ask you about is the pre-peritoneal packing that I got to do during the ASCET course, the emergency war surgery course. Is that something that you think would be possible for an advanced trained medic in the field?
My experience with the medics, at least that I've come across, both the 18 Deltas and 6-Day Whiskey 1s, who I've taken to the operating room with me, I think can learn that quite easily. Is that a good alternative, the pre-peritoneal packing? I think you're going to find believers and non-believers. I've worked with both. Bad arterial bleed in the retroperitoneum, it really may not work. But I do not think that it is a futile exercise all the time, specifically with venous bleeding. And 80% of those bleeds, 85%, depending on the literature that you're reading, will be venous bleeds. And I think that's something that's really worth attempting. And the problem with that is if you're not experienced with it, especially in live tissue, cadaveric tissue, fresh cadaveric tissue maybe, but non-fresh cadaveric tissue just does not have the same feel. And remember, when your adrenaline is rushing, and if you're wearing gloves and so forth, getting into the retroperitoneum, even in a we would say a virgin abdomen, still takes a little time. There's a lot of blood coming at you, and your adrenaline, your catecholamines are rushing like crazy, and that's the time where you just need to kind of take a deep breath and slow down and pack without getting into the peritoneal cavity, because once you do that, it's they could bleed for the rest of their life.
With any of these surgical procedures, it's one thing to receive the instruction, no matter how amazing it is. There's another to stay fresh on it so that when the time comes, you can do it effectively. I guess how frequently, you're doing it every day, but how frequently should somebody who has received more advanced training be refreshed on a given procedure?
Well, I think you've hit the nail on the head, and that's something that many busy trauma centers struggle with. I will be the first to tell you that I don't do retroperitoneal packing every day. That being said, I spent years and years getting into the retroperitoneum, both in transplant and trauma, and on occasion in general surgery, doing hernia repairs and so forth. But what does the 18 Delta get? And the 18 Delta probably gets, or the soft medic, if you will, they get, a class, right? And one of the reasons why we spend quality time together once a year, or even twice a year, once a year for a month, or twice a year for 2 weeks, is so that you get that refresher that you haven't had potentially in, months to years. I don't know that the 18 Delta or the soft medic has the competencies to do these things well. And so that begs the question, well, what are you supposed to do in an emergency? And like a person much smarter than me once said, you stoop to the level of your training rather than rise to the occasion. And if you've seen it and you've imaged it before and there is nothing left, I think, you have a responsibility to your teammate and to that community, if you will, whether it's yours or the indigenous community that's looking for, help from you guys to proceed with whatever you have.
If you had your way, you're a king for the day, how frequently would a medic who is expected to be able to do these more advanced procedures, how frequently would they practice them?
Another great question, which I do not have the answer for. However, there are several studies out there looking at things like ultrasound and other procedures that we do on a routine basis. And then you've got people that say, can't even think of the author's name right now, what it takes to be an expert at something. I don't think you need to be an expert at placing REBOA. I think you just need to be good enough. And good enough is undefined. But I would guess that you would probably need 50 of these procedures at least to reliably deploy a REBOA. And to reliably deploy a REBOA in a very critically ill, critically injured patient doesn't just mean getting access with a needle. It means being proficient enough to get into the groin and dissect the groin out as violently but as safely as possible to identify the femoral artery. And that takes a number of attempts to do that skillfully, especially in a young person who has very strong virile tenacious tissue. And 50 may seem a lot initially, but I think somewhere around your 48th, you're probably thinking, man, I only have 2 more to get this perfect. And so if you can do 50 and you do 50 every 2 years, that may be enough. And that is just a number. That is a number based on other procedures, not on REBOA. So I don't know what it takes to be. I don't know that we've studied how many it takes to be proficient at a REBOA. My guess is somebody has an abstract out there and probably may have found it much less. But again, these are in surgeons, trauma surgeons who access the groin and have access to the groin multiple times.
Mm-hmm. Another procedure that I've talked about is shunts, providing shunts for limb reperfusion, as opposed to leaving a tourniquet on. But if I can repair a vessel, I can reperfuse that limb. What do you think about 18 deltas or SOIDCs? Somebody who's got more advanced training, placing shunts in an austere environment.
Well, I think it's a great temporary procedure, and I think it would. There's a lot of what makes a trauma surgeon is not necessarily the trauma surgery. What makes a trauma surgeon is the decisions that are made to do corrective surgery. And if you're going to place a shunt, you can almost guarantee that there is going to be a very large hematoma. And that hematoma, if disrupted, will cause, audible bleeding, torrential audible bleeding. And so getting proximal and distal control of that vessel is the art of vascular surgery, which many people do. Now, some people will teach to go right into the hematoma. I think these are very skilled, very deft, and experienced surgeons who go right into the hematoma. The 18 delta would probably have to get proximal and distal control, which takes time. But it could potentially be done based on the types of injuries that they're seeing. In other words, these big blast injuries with big open wounds where a lot of the dissection actually has been done for them by the blast. And if they can occlude that artery, both proximal and distally, and see the hole, and they have the right shunt, potentially they could save a lot of tissue. They may not save a limb, but that is not necessarily always the goal. It may just be that you're saving a lot of tissue, which saves them an enormous amount of energy in mobility. And with that, some significant morbidity and potential mortality. But once they reperfuse that limb, and they need to do it quickly, what do you do with the excessive bleeding at the end of that limb? And it may just mean a tourniquet. So, again, the most important thing is not necessarily the shunt, it's the decisions that go around identifying the correct patient and the technique in placing the shunt and what to do with the patient that you've just saved.
And Mark, when we're talking about shunts, if it's a limb that's been, under a tourniquet for an hour, maybe hour and a half, you're getting to the point where you have to start thinking about this, or it's going to be too late. What is the role of thrombectomy? Getting up in there and clearing out that clot before reperfusing that limb.
There is a role, but I just do not think that the 18 Delta, in the conditions, the environment that they're in, is prepared to really do a thrombectomy unless they have led another life prior and spent time doing that. These balloons are exceedingly fragile, and you could imagine your teammate or a guy in another team, whomever, requiring a thrombectomy, and with all the adrenaline, all your catecholamines going, your tactile senses are not exactly made to appreciate the tensile proprioception needed to inflate that balloon large enough but not small enough to do an embolectomy.
Yeah, I've definitely seen somebody pop the balloon when it's in the artery, and then there goes that whole thing. But I mean, is it one of those things that's critically important to, basically go in there and snake the vessel out before you tried something like a shunt?
Well, if they're coagulopathic, definitely not. And no, I don't know that it's critically important. I don't know. Having a foreign substance such as a shunt in a vessel is thrombogenic in and of itself. And the likelihood of that patient being coagulopathic is pretty high. And with the encouragement of TXA early on and so forth, the likelihood of clot is high. And that's what we balance. It doesn't matter whether it's the battlefield or in a civilian hospital. We're always balancing. You and I right now are balancing between clotting and bleeding. And it's a fine line to deal with. And then you add transfusion and trauma, and it's a mix. And I think your goal is to get that patient to whether it's a roll, 2 or 3 as quickly as possible.
Yeah, I would absolutely agree with that. And most of everything we're talking about right now, besides blood transfusion, is outside of our current scope. I think we're looking at, advanced courses like the Regional Support Medic course and other training events that may increase the scope. And we're just trying to probe around and see what is possible and also what's needed. Sometimes we may be looking at something and it's such a low incidence that, do we even need to look at that particular procedure?
I think you hit the nail on the head, and so did Dennis early on. Just because we can doesn't mean we should. And will we get the anecdotal patient that lives? And the chances are you might in a large period of time. Remember, it was the British, I think, that actually had 12 patients who survived an open thoracotomy in the civilian field. And they published it, and everybody was like, "Oh, we need to equip our paramedics now with, thoracic trays so that they can do a thoracotomy in the field." Well, thank goodness we haven't. They're not trained to do that, and we know that the best thing for these patients is to get them to a hospital as fast as possible. And everything you described so far takes time. What do you do in this era of prolonged field care and having, these incredible warriors, the 18 Deltas, these soft medics, do advanced maneuvers? Again, I think it's worth asking the question, but right now I don't see any advantage in doing some of these things until we get them better trained. And they have incredible training. I've seen it. I've worked with you and others, and I am always impressed, not only by their work ethic and the things that they have been trained to do, but their ability to work on the run, think. They can outthink just about anybody. They can come up with things that most people would give up on. And these are the right people that I would invest in that training. but it's not ready for prime time, and I wouldn't advocate it for it at this time.
Right.
That's fair enough.
And I think, with cases, like the British case you're talking about, with REBOA, that was also the British, I think, were the first to do a pre-hospital REBOA. They look at an isolated case in that somebody lived, but they didn't really tease out, did he live because of the procedure or despite it? Just because, we have one positive view, should we, change a scope of practice to include, these very few incidences?
Agree. The denominator is really not known, is it? And we're comparing one success to an unknown denominator. And there will be, if it were approved, say now, there would be a lot of people who are potentially dying because of the delay in transport. And if you look at one of the greatest advances we've done, among the many, many great ones, one of them is the do not stay and play. and that is to load and go, right? That's kind of been the mantra for a few years now, and it has really improved the care of our patients. And that's why I say the heroes are not the trauma surgeons. The heroes are the boots on the ground, the paramedics, the pre-hospital folks that make the right decision and to package these folks up. If they can do something in the truck, like start an IV, that's great. But if not, get them to the hospital where we have a team that's prepared to do advanced care on these folks.
Mark, I do have one other question. When you're talking about decision making and the ability to make decisions with telemedicine, I'm able to communicate outside of where we are to an expert such as yourself. With these advanced procedures, would you be able to provide guidance and maybe even a walkthrough of how to do a procedure via telemedicine?
Absolutely, and you'd have to talk to experts like Colonel Shackelford and many of the other great resources you have, Dave King and so forth. But the answer is yes. Whether it's a civilian trauma surgeon like myself, or a reservist or somebody who does have experience, I think telemedicine is the way to go, and that is probably how you're going to be able to advance care with things such as REBOA and retroperitoneal packing and maybe even shunts and damage control or damage control resuscitation or laparotomies. I think those are way, way, way far off, those open procedures. But the more minimally invasive ones, through the advent of telemedicine, could make the reality of it come much, much more quickly.
And
yeah, I think we always look at the worst case scenario if we're in the middle of Africa, if we're somewhere else, and the trauma surgeon is not there. That's why we're always kind of trying to push the boundaries of this. And if you look at the military in general, with 28 trauma surgeons for, 1 million troops, one thing I wanted to ask you is what got you involved in this training in the beginning, just so that we can help educate other providers out there that may be able to help get 18 deltas and SOCMs trained up to a higher level and to be more proficient in what they already have. And then in the future, we can look at additional things. How would you help us recruit people into this effort?
I do that on a regular basis, but it's got to be the right environment. And the place that I initially started the MPT was really a phenomenal education for me, but it really wasn't the right environment for the 18 Delta. It was a very, high profile elite university where they really could not do things, but they shadowed. They were able to talk and converse with some experts, and we had a very, very narrow scope of practice, but were, highly, highly proficient in that narrow scope. And the volume of cases were really kind of, I wouldn't say minimal, but they were just moderate. I took that to a very high profile, a very, very proficient, very large trauma center in the United States, in the southern United States. And they were able to not only see an enormous volume of trauma patients, which, by the way, wasn't the general civilian trauma with a handgun, but these were rifle injuries. These were very, very high-speed, blunt trauma injuries, very, very violent stabbings and slashings. And so I was able to introduce what the 18 Delta can do. I think one of the things I did at the initial place that I started the MPT was to have the 18 Deltas present once a month at a trauma conference. And what they did initially was week after week, it was a capabilities briefing until everybody kind of got the idea that these guys were super special. And so that opened up the door for many other opportunities for them, but again, not at a high volume trauma place. It gave faith to those who were training them to let them experience a little more and a little more. And they were always competing with residents who wanted to do the same. Whereas most recently, the place where I opened up the MPT, the volume is so high, and the autonomy for the trainees are so wide open that they invite the help of the medics into the care of these traumatically injured patients. So no longer are they just bystanders and just asking questions, but they are actually doing procedures, and some of them are quite major procedures. And the level of training at that place is much better. So I think that's the biggest thing, is once they see the 18 Delta and the capabilities and the interest and really the raw enthusiasm, it's very easy to spread the mantra about our civilian and military collaboration. And that just has to go on, because sooner or later we're all going to kind of be in the same boat, because there is no doubt that we care about the traumatically injured, but we need to care about the person downrange as well. And to do that, you need to equip these 18 Deltas with the experience that many of us have. And if they over experience it, that's not a bad thing. We have to find that line between training our residents and fellows and training the soft medics, because downrange, they don't have anything that we have. They're more than capable of thinking through a situation, but they need the experience to think of what they need and to make the correct decisions.
Yeah, we really appreciate all you've been doing for our community.
Well, not as much as I appreciate what your community does for this great country. And I've said it before, and I'll say it again. Thank you. My son says it. My son goes in the airport, and every time he sees a uniformed soldier, he thanks them for their service. It's that important.
Thanks, Mark.
Thank you. I appreciate it.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you. Come and take it all to drag me away from you. There's nothing that 100 men or more can ever do.
All right, guys, I think that's good.
Great. Look forward to seeing you guys, hopefully in, I think it's April.
Yeah, I think April. Are you going to come out to the international one?
Oh, yeah. Yeah. I mean, I cleared my calendar. Everybody knows you can't touch me. I will be there.
Okay.